Welcome to everyone. My name is Eve Tupper, and I direct the Duke Center for Global Mental Health. So on behalf of our center, along with the co-sponsors, which are the Duke Center for AIDS Research and the Department of Psychiatry and Behavioral Sciences, we are very glad to have all of you here in person and online. Before we get started, for the online participants, there should be a Q&A place where you can put in questions throughout the webinar, and we'll get to as many of them as possible. So yes, feel free to do that. And I will get started because I'm very excited to introduce our speaker for today. One of our goals as this center is to bring people together to hear from speakers outside of Duke and within Duke who share some of our common interests, but who also bring unique perspectives. And so in that spirit, we are glad to welcome Dr. Jasper Lee today. So Dr. Lee is a clinical psychologist in the behavioral medicine program in the Department of Psychiatry at Massachusetts General Hospital and a faculty member at Harvard Medical School. And his work, which we'll hear about today, focuses on behavioral medicine, supporting people who are facing both psychological and mental health problems, especially in the context of chronic illness. So clinically, he uses cognitive behavioral therapy to treat depression, anxiety, PTSD, and substance use disorders. And then his research develops interventions for individuals facing both psychosocial and structural barriers to HIV treatment in the United States and globally. And he has had support from the NIH and from the Harvard Center for AIDS Research. So today, Dr. Lee will present his global program of research related to addressing syndemic problems related to psychosocial and structural intervention research. So join me in welcoming Dr. Lee.
So I'm gonna sit because I broke my foot. Those of you on Zoom luckily can't see that, but I don't think I can stand for a whole hour. So I'm going to be talking about my work on syndemic problems in HIV, both domestically in the US and also some of the global work I've done in South Africa and Zimbabwe. And these are my affiliations, collaborators, and funders. I don't have any conflicts of interest. I do get funding from NIMH, Brigham and Women's Hospital, Harvard CFAR, and the MGH Gun Violence Prevention Center. So I want to talk sort of about what I'm going to talk about today, which is first a primer on syndemic theory, syndemic problems. Maybe it's a refresher for many people, as well as modeling approaches for how we look at syndemic problems. Some of the work I've done in low and middle income countries and in the US previously, the work I'm currently doing in South Africa and Boston, and very importantly, in this current funding climate, how the domestic research I'm doing builds off of the lessons I've learned globally. For those in the room, feel free to ask questions as they arise. I cannot see the Q&A, so if you have something in there, drop it in there and we'll get to it. This is sort of broadly how I think about my research interests falling into these related overlapping areas held together by syndemic problems, but kind of cross-cutting HIV and other infectious disease, resource-limited settings, intervention development, mHealth, and also getting into some gun violence prevention work, which I'll touch on today briefly, even though this is mostly an HIV talk. So this is a slide from the CDC about HIV prevalence in the US. This is 2023 data. The US has about a 0.34 prevalence rate of HIV, but it's very uneven. It's concentrated mostly among men, mostly among Black and African American folks, and mostly in the geographical south of the United States. In contrast, resource-limited settings like Southern African Development Community countries like South Africa and Zimbabwe have a more generalized HIV epidemic. The prevalence of HIV in South Africa is almost 20%. It's about 10% in Zimbabwe. It's a much different landscape. But these high prevalence rates don't occur in a vacuum. They occur in the context of psychosocial and structural problems that perpetuate these health disparities. Things like depression, substance use, alcohol use, post-traumatic stress disorder, food insecurity, poverty, and housing instability. Within that context, though, these problems aren't in silos. They're interrelated. And so I think one of the limitations of understanding the effects of comorbid problems is looking at them separately, like this. And what we really want to start to do is look at them in an overlapping way. And so one way to think about that is syndemic theory, which thinks about comorbid psychosocial and structural problems as interacting with each other synergistically, which increases the risk for worse health outcomes, whatever your outcome of interest is. In my case, that's HIV. And so it really, they come together and form this syndemic problem within your health problem context. So the term syndemics is a portmanteau of synergistic and epidemics. And it was first used by Meryl Singer, who unfortunately recently passed away, in the 1990s to describe the factors contributing to the HIV/AIDS crisis then as a set of synergistic or intertwined and mutual enhancing health and social problems. And the idea is that because these things are intertwined, you can't just look at one if many are occurring. And so the question then is, how do you actually model syndemic synergy? And there's a lot of really good literature on this. My colleague Alex Tsai at HMS has published, and MGH has published a bunch on this. Probably the most common way to do this is additive effects. And so if you take the idea with additive effects is you can take the effect of one problem, add it with another problem, and you get the effect of two syndemics on your HIV outcomes of interest. And then you can do 1, 2, and 3, and you get the effects of 3 syndemic problems. And the idea is 3 is worse than 2. And we can model that pretty easily with a regression equation. The problem with additive effects approaches, though, is there's no real statistical consideration of how synergy is involved. Another problem with additive effects is like which 3 problems. It must matter which 3 you have. Someone with depression, PTSD, and food insecurity looks a lot different than someone with IPV, housing instability, and substance use. We know that clinically, but if you use this approach, you don't get that granular definition there. So one other way to model these is interaction effects. And you can take 3 specific problems like depression, PTSD, food insecurity, model the interactions between them, and come up with sort of the effect of these 3 specific syndemics and their interactions. And the idea here, this is a theoretical diagram, is that the effect of these 3 syndemics and their interactions on HIV would be worse than the additive only approach. So that sounds really great when you have 3 syndemic problems. And we can model it pretty easily. There's a regression equation. If you're not a stats person, don't worry. That's pretty straightforward. The problem, though, is if you have 10 syndemic problems, which seems to be how syndemic research, including my own research, is done, is here's a lot of problems, let's look at them. Okay, well, now what? Well, you can't really model interactions between 10 syndemic problems. You get a regression equation like this. If this slide is overwhelming, that's good. It should be. It's overwhelming to me. We don't do this. And so what we need is a way to reduce these data. We need to get out of many few. And there are many different data reduction methods you could use. You could use theory. That's one way to do it. The problem with using theory is it can open up bias. So what you're interested in might be different from what I'm interested in. We might use different behavior change theories, and we might come up with different problems we're interested in and miss a lot of what's actually going on for people. So you could use empirical data reduction methods like machine learning, or like this other one, stochastic search variable selection, which apparently if you take statistics 216 here at Duke, you can learn about it in lecture 7. I have used network analysis as a data reduction approach. It's more than just this pretty picture here. This is a network from Sasha Epskamp. There are many things I like about network analysis. One is I think it's theoretically appropriate for looking at the synergy inherent to syndemic problems. There are also some nice statistical things that you get from it. You get a penalty for multiple comparisons. You don't need a latent factor. There are actual empirical indices of centrality, which tells you how important a variable is in that network, how influential it is over other variables. You can do clustering analysis, and you can start to, all of what I was just talking about with interaction effects models, you can start to understand different relationships between the actual variables you're interested in. An approach like machine learning will spit out a set of factors, but you don't really know how those work together. And if you're at 4 or 5 important factors, it can start to be a little bit complicated statistically how you would model that. So I like the use of network analysis to look at specific interactions. This is a network of symptomology. How do symptoms within a disorder cluster together and come together to create this disorder, whatever psychological disorder you're looking at? One order above that is a syndemology network. How do different psychosocial and structural problems come together within your syndemic? And so that's what we started to do. We started with network analysis of men who have sex with men in the United States, just to understand, like, can you even do this with syndemic problems? What does this look like? So turns out it actually works, and there are some interesting findings that you can take from these analyses. And we started to extend this to South Africa as well. I'm going to talk a little bit more about this study specifically. This was a study built off of a larger R01 trial. We just did a basic clinic convenient sample of who comes to get care at clinics in Khayelitsha, which is a township outside of South Africa. I'll talk about that in a second. We had 194 people at 6 different primary care clinics. All people had HIV, but we had general inclusion criteria. We didn't select anybody for specific mental health problems or specific HIV clinical outcomes like detectable viral load or missed adherence, just who's getting care here. We had a one in-person visit at baseline, and then 12 months later, we did chart extraction for adherence and viral load. So I want to pause for a second and talk about townships in South Africa. For those of you who are not familiar with townships in South Africa, they are, they were created during apartheid as a form of racial segregation, and unfortunately they persist today. They're one of the most under-resourced areas of the entire world. On the right are some photos I've taken on my trips to South Africa in townships. And on the left is the cover of Time magazine from 2019, which says the most unequal country in the world. And you get this really stark image of, on the right side of that, a township, and on the left side, a really nice gated community with swimming pools. The reason it says the world's most unequal country is South Africa is the country in the world with the highest income inequality. And so coming back to our study, what did we find? We found really high rates of syndemic burden and psychosocial and structural problems. And I'll talk about this in a second. We looked at 10 different syndemic problems. Like I said, you can't do interactions with all of those. So we wanted to understand what was going on there. So a third of the sample had 2 to 3 syndemic problems. A third of the sample had 4 or 5. So just imagine what it's like to experience any 5 of these problems all at once. And then most of the problems we looked at had prevalence rates of about 33%, about a third: depression, alcohol use, IPV, PTSD, social anxiety, poverty. Except some were lower. Substance use was quite low at 8%. But food insecurity had a prevalence rate of 81% in our sample, which is just mind-boggling. And I said, these are just people who are coming to care for the clinic. We didn't select them for any sort of predisposition to have food insecurity. So there's a really large problem with food insecurity among people with HIV in Khayelitsha. So what is food insecurity? I know you all recently, there was a lecture on this, so I'll be brief, but it is not having physical, social, economic access to safe, sufficient, nutritious food for your dietary needs and preferences. And it's a huge problem in the world. More than 2 billion people experience at least moderate food insecurity, and about 10% of the world experiences severe food insecurity. So moderate food insecurity is eating less food than you would like. Severe food insecurity is having no food. You can see the FAO has identified some hunger hotspots, parts of the world where hunger is a large problem, and this is only going to get worse. I'm going to read how the UN described it because it's very diplomatic. The ongoing conflict affecting the Strait of Hormuz region is disrupting energy and fertilizer flows with measurable impacts on costs and growing risk for food systems. So food insecurity is only going to get worse. When the war in Ukraine started several years ago, the problem of food insecurity in South Africa became much worse because Ukraine is one of the largest wheat exporters in the entire world. And South Africa got a lot of their wheat from them, and then that was abruptly taken away. So one thing that's important is to understand how we measure food insecurity. I talked a little bit about what is moderate, what is severe. So this is one measure that's often used in low and middle income countries, is the household food insecurity and access scale. It measures food insecurity at the level of the household, not the individual, in the past 30 days. So relatively recently, in the past month, how often have you experienced any of these problems? And food security is not worrying about whether you would have enough food. And then anything more than that is food insecurity. And there's lower quality, lower quantity, and then no food at all for at least a day in the past 30 days is severe food insecurity. One thing I always think is important when you're starting out looking at a new problem, at least for me, is to understand how we measure it. Does it actually work? Can you actually measure it in the people you're doing the study with? And so we did a quick study of that, and it turns out you can use a sum score. And then there were also some important factors within that. And I really wanted to take a second to highlight that no food intake, these last three items, was its own factor and has its own level of importance. And we'll talk about why I think that is psychologically as well. Why am I talking so much about food insecurity? Let's talk about HIV. It turns out that food insecurity is a major structural barrier to HIV care across the continuum. Worse access to care and medication adherence, worse immune functioning and viral load, worse survival, higher likelihood of HIV acquisition, and higher likelihood of depression. So it's a major problem, cross-cutting a lot of the areas of HIV care. So we did this network analysis of these 10 problems, and I'm just going to pause here for a second. So you'll see that there are different clusters represented by different colors. So there was this mood and violence related syndemic problems cluster, a structural syndemics cluster, and then the substance use, alcohol use, and structural barriers to care. There are also, from this network analysis, we got measures of centrality, so the influence one variable has over other variables. Depression was the most influential, followed by substance use, which is really interesting because substance use prevalence was really quite low at about 8%, but still was very influential. So for people with substance use, it's very problematic. And then food insecurity, and then post-traumatic stress. You can also see, you don't really do significance testing in networks, but a lot of journals can't get around the fact that you can publish something without a p-value in it. And so we did those anyway, and there was a significant connection between depression and food insecurity, which I'm going to talk about more in a second. But so this was a network of syndemics among people with HIV in South Africa. We wanted to then test this question: can you use networks as a data reduction method to look at interactions among syndemics? It's kind of a wordy slide. I'm sorry, the text is a little bit small. We did 5 different models: an additive only with a sum score, additive with free beta weights, interactions, and then just the most central problems, and then interactions in those. And this is the 5th model, which is just the kind of more parsimonious model. But there was a significant interaction between depression and food insecurity. So I personally can't tell you what an interaction on beta means without looking at a graph. So we looked at that. I'm going to stop for a second. So there was this interaction between depression and food insecurity at baseline on adherence over the next 12 months. And what we found was that people with higher than average for the sample food insecurity, so this is in a sample with 81% prevalence of food insecurity, so the people with the dark blue line was really high food insecurity, their adherence was untouched by depression values. It did not matter what your depression symptoms were, your adherence stayed the same. It was really high here. And I think part of that is people come to the clinics for care, and they come to the clinics when they're struggling most. And so they were able to stay engaged. These people were able to stay engaged in care despite having really high food insecurity. But at lower levels, just average, which is still high food insecurity in this sample, and then below average, you can see that as depressive symptoms increase for those with food insecurity, their adherence decreases in that 12-month period. So there's something going on with depression and food insecurity. I think we probably know what that is. If you go back to Psych 101 and think about Maslow's hierarchy of needs, we know that physiological needs come first. Food is an important necessity, it's a basic need, and you can't really think about depressed mood, feeling down, sad, low, or anhedonia, loss of interest, loss of pleasure, when you're so concerned with where's your next meal coming from. It's a much more salient stressor, and it kind of overwhelms the psychological effects that depression might have. We found a similar relationship among people with HIV in Zimbabwe, presenting, this is from a baseline visit of a depression intervention trial. So people had some indicator of depression in this, but when people had moderate food insecurity, people without depression had better adherence than people with depression. So depression interacts with food insecurity on medication adherence. And so this work kind of was the foundation for eventually a successful Harvard CFAR Developmental Award and NIMH K23, which the K23 used to be called Developing and Piloting Multilevel Intervention to Address Psychosocial and Structural Syndemics in People with HIV in South Africa, but I had to remove some words. And so there's the four aims. The first aim is a qualitative analysis to look at how do syndemic problems work, how do they interact, and what are people's intervention preferences. The second aim is to actually develop a multi-level intervention that I'm going to talk about a little bit more today, do a small pilot. Third aim is a larger feasibility, acceptability pilot trial, randomized controlled trial of this intervention. And then we're also going to collect some implementation science outcomes to inform what will hopefully be a future R01 at some point in the whenever funding comes back online. This is the conceptual model from my K23. I'll talk about this for a second. We have on the left the three syndemic problems we looked at. I get the question a lot, why didn't we include substance use? Because it was an important syndemic in the network. The problem is rates of substance use are quite low at the clinics. You have to really get out of clinic-based recruitment to get people using substances. And a K just doesn't have the infrastructure to do that. So we hypothesized that depression and post-traumatic stress would lead to avoidance and withdrawal. And through that, we'd have worse HIV outcomes. And food insecurity would lead also to its own barriers to adherence, and through that, worse HIV outcomes. So we have, we've done the qualitative scope of work in AIM-1, and I'll present some preliminary qualitative analyses and results from that. Basically, our demographics in the sample were about 40 years old, mostly women, 60% met criteria for PTSD, 66 for any major depressive disorder, past or current or recurrent. And then almost everybody had severe food insecurity. We did screen for that, but we didn't screen at the diagnostic level. So these are pretty high levels. There was also about a 50% alcohol use disorder rate. And most people had 3 syndemic problems. So some of the barriers to medication adherence that we found are things you would expect. Food insecurity was a barrier, interpersonal stressors, medication side effects, alcohol use, employment. A lot of people hide their status even from people in their own family, and so they hide their medication. And that can also lead to forgetting or changes in your schedule. And then depressed mood, PTSD, negative affect was also its own barrier to medication adherence. We also asked people directly, how does food insecurity interrupt your ability to engage with HIV care? And how does it affect your life? And people talked about borrowing money, not being able to work because of having food insecurity in this sort of cyclical way, it affecting their mental health as a barrier to ART adherence and clinic attendance, interrupting daily functioning, everyday tasks of life, this sort of chaotic life where you're going around looking for food in many different places, relying on different people, physical symptoms, social functioning problems. Alcohol use kept coming up in different ways in this interview. We didn't recruit for alcohol use problems. It just kept coming up as an unhelpful coping strategy, and then stigma around not having enough food. So one participant put it, we have a lot of quotes like this, unfortunately, but people describe food insecurity as just an overwhelming stressor that interferes with every aspect of their daily life. And one participant said, I won't feel like myself. I won't be able to do things normally. I mean, when you have not eaten, you can't even think straight. Or if you don't have food at home, you're only thinking about one thing, that I'm hungry, that's all. And you're not thinking about anything else. People also, when we asked about food, gave a lot of answers that sound a lot like depression. So on the left these are quotes about food insecurity, and on the right are the symptoms of depression that they map onto. And if you were just doing a diagnostic interview and asking people about their experiences of these things in the past 2 weeks, it would sound a lot like that person is depressed, but they might not be. They might just be experiencing food insecurity. Then we asked about the effects of depressive symptoms. And again, I think mostly what you would expect. People talked about all the different aspects of the symptomology of depressive symptoms, including suicidal ideation. Pain in one's heart is a cultural idiom of distress. And then many of the symptoms you would ask about on diagnostic interview that led to social isolation and withdrawal and avoidance, things we hypothesized in the conceptual model, low motivation, poor concentration, poor self-care, and then behavioral inhibition, worse social functioning, worse physical health, and again, alcohol as a coping mechanism, also smoking cigarettes as a coping mechanism. So in thinking about this behavioral inhibition, participants described sleeping a lot, watching TV, not really interacting socially, and then alcohol use. And one woman said, when I'm down, it's like I want to be alone. And when I'm worried, I feel like closing myself indoors, because when I'm worried or when I'm moody, people will be busy asking me questions and I would be feeling what I'm feeling. And people won't understand what I'm feeling. So what I usually do is close myself inside the house. When I'm feeling like that, when I'm feeling down, I sleep. No, I don't even care about my health. I just sleep. We continued asking about individual problems, so also post-traumatic stress, and we had all the different criterias of diagnosis there that people talked about. Also interfering with social support. It was again a barrier to medication adherence. A lot of people talked about feeling like a failure, feeling devalued as a human as a result of their traumatic event and the subsequent post-traumatic stress symptoms. Shame came up a lot. Again, alcohol use. One person said, I take my anger out on people that I'm not supposed to take my anger at, and it affects me in a way that I can't communicate with people about the situation that I'm in, and I can't share with people. And I think this quote is important because we can understand that social support is an important coping mechanism for all these other aspects of life. But if you are systematically predisposed to not engage in social support well or access your social support networks well because of PTSD, it becomes its own barrier. And then we ask people, this is a hard question, how do these things work together? Most humans don't think about things this way. I think some clinical psychologists do, many other fields do, but it's hard for people to start to put this together. People talk about wanting to escape, and suicidal ideation came up a lot. Physical symptoms came up. Unhelpful coping strategies, again, alcohol use and other things like behavioral inhibition, emotional avoidance, social isolation. They did touch on the synergistic effects. Obviously, nobody was using that word, but that's what they were talking about. And then out of the many problems we asked about, food insecurity was identified by people as the primary problem among all of the syndemic problems they were experiencing. And one person talking about the synergy said, when they are combined, they really make me have trauma. They are all painful things. Not having enough food is painful. Not having enough food is painful. But being hungry is painful. And these things that happen to me, they are also painful. They make me feel very depressed. And sometimes I have a decision. If I would have a gun, something that would make it quick, or maybe get pills and just take them and no longer exist. So when these things combine, all those things that affect me, I think it's just better for me not to be around, not to be alive anymore, because all these things are happening to me. And when I combine them, I think this thing happened and this one also happened. And while I'm thinking about this one is happening. Why are all these things happening to me? Why am I experiencing things like this? So if I were to change the conceptual model, I would add alcohol use back in. And I'd also have food insecurity as having its own path to avoidance and withdrawal. That came up a lot. It's not just psychological problems through food insecurity, but it's its own contributor to avoidance and withdrawal. So we're developing this intervention, a multi-level intervention to address syndemics and adherence. We call it Project Umbona, which is the Isimoso word for maize or corn. So it's a multi-level intervention. All participants in the study get 3 food parcels, 1 per month. The food parcels are quite large. I'll talk about them in a second. And then one condition gets the cognitive behavioral therapy on top of the food parcels. But as I mentioned, everybody's getting food parcels about once a month. So this is what the food parcels look like. We work with an NGO called Food Forward in South Africa that is providing us with them. They contain shelf-stable foods, a fair amount. There's like a 2.5 kilogram bag of maize and a 2 kilogram bag of rice, and then peanut butter, some kind of protein, canned fish, canned meat, things like that. I get the question a lot: why food parcels and not an unconditional cash transfer? And I think there's a lot of merit to an unconditional cash transfer, but it's a little bit more complicated. One thing is the food parcels are a direct food insecurity intervention, and I think that that's important in the context of high food insecurity. There are also nutritional deficiencies linked to depression, affecting neurotransmitter development and things like amino acids and B vitamins and minerals. And then I think psychologically, having a food parcel enhances someone's self-efficacy and problem-solving skills, which are things we're trying to teach in the intervention. How do you pick it up? How do you get it home? What do you do with it? How do you share it? How do you not share it? These are all things we can talk about in an intervention. It's also important to think about coercion. And if you just give people cash, is that really coercive? Food parcels can also be coercive, but I think it's slightly different. And then also, like, food banking models exist in the world. They reduce food waste. There's a lot of food waste in the world. And if we just give people cash, we contribute to sort of the ongoing system. But if we can rescue some food from being wasted and actually divert it to people who need it most, that might be a more sustainable path forward. So the intervention itself is 6 sessions. well, it's really 7 sessions because everybody is also getting a pre-parcel session where we assess for what is their current food insecurity experience like, what is the safety of getting this food parcel, how do you plan for it? You're about to get a lot of food. How do you get it home safely? Once you're home, how do you use it safely? If there's intimate partner violence or other problems at home, we want to know that before we give them a parcel and either plan around it or decide whether there should continue in the study for safety reasons. Then sessions 1 through 6 are the CBT part. So we're developing an adaptation of life steps, which I'm calling food steps, to identify barriers to food insecurity and generate a plan and a backup plan for those. I want to be really clear that I don't think there's a problem-solving solution for food insecurity. It's not like, oh, did you try this thing that you never thought of and now you're not going to be hungry anymore? No, but that's not the goal here. The goal is to help people overcome controllable factors relating to food insecurity, but it's not going to magically make food appear. Then session 2 is Life Steps. Life Steps was developed by my graduate school mentor, Steve Safran, in like 1999. It's a 1 session evidence-based problem-solving intervention for HIV medication adherence. It is also the standard of care for Médecins Sans Frontières in South Africa for adherence counseling. Then we're doing a problem-solving session that builds off of these 2 previous problem-solving-esque sessions, 2 behavioral activation sessions, and relapse prevention and linkage to care. I don't think these 6 sessions are sufficient to treat post-traumatic stress disorder or treat major depression. I don't think they're enough to treat both of them at the same time, for sure. The goal of this intervention is to simultaneously alleviate some of the stressors that these syndemic problems cause. So if we can give people food, my hypothesis is that they'll be better able to uptake the CBT skills. If thinking about Maslow's hierarchy, if you're really hungry sitting in a session and someone's talking to you about problem solving, you just don't care. It's not going to touch your problems. But if we can give people food and then teach the skills, they might be able to better incorporate them into their lives. And then that might be enough with the skills to sort of start to break the cycle, re-engage in care, figure out a system that works for you. And it might be enough, we'll see, to sort of break this cycle in a longer term way. But I don't think we're like treating depression or treating PTSD in this intervention for a curative intent. This is a little bit about what Life Steps is. There's different topic areas that are addressed that are common barriers to medication adherence, and everybody identifies their goal, identifies the barriers to reaching that goal, and then for each barrier creates a plan and a backup plan. And so food steps is built off the same idea. What do you want to accomplish? What are the barriers? And then how do you cope with those things? And here, there's a list of some common barriers to food insecurity that we've sort of garnered from the qualitative work that we've done and other prior research too. So the main outcomes of my study is primarily a feasibility and acceptability study. Does CBT SA actually work for people? Can we actually do it? And then is it actually effective as a secondary outcome? And we'll look at ART adherence at 6 months, and then depression and PTSD at levels via diagnostic interview. We'll also look at food insecurity. We're stopping the food parcels at 3 months, so they'll have 3 months between their last food parcel and our final follow-up. And then we're going to look at some implementation factors as well. But we don't have these problems in the US, right? Depression, PTSD, food insecurity. So how can we take what we've learned in South Africa and apply it here? Unfortunately, we do have all of these problems in the US. We have these problems locally in North Carolina as well. And so we've done some work in Boston using NHBS. Homelessness was associated with actually more PrEP awareness than not having experienced homelessness. But clearly there are structural problems that are important for HIV treatment and prevention in the US here. We've also been using some mHealth approaches including something called digital phenotyping, to look at syndemics. And so we can actually take data from your phone and understand what it looks like when you're experiencing different syndemic problems based on your phone usage. GPS is one that we use. So this is a de-identified map of what it looks like, what someone's GPS looks like in a day when they're having different problems. This is in substance use. This study isn't published yet. We're writing it up right now. But these are GPS-based phenotypes of depression, food insecurity, and medication non-adherence among people with HIV in Boston. We're also using digital pills. If you're not familiar with digital pills, there's a picture of them, image A there in the middle. It's your normal medication, which is over encapsulated with a gelatin capsule. Inside that gelatin capsule is a radio frequency emitter that's turned on by the stomach acid. And you wear that reader below it. There's that one is a lanyard. There's also a watch band based one, and they're making a sort of like a in-home reader that has a larger range. And it can actually tell when the pill has been swallowed because the RF tag is activated. So we can use that. We've done a pilot study that we're also writing up right now among people with HIV and tuberculosis in South Africa, asking about digital pills, except like whether they're acceptable. And most of the people specifically for TB adherence, it's a different adherence pattern than HIV. Would you take digital pill instead of directly observed therapy? And actually, most people in our study preferred digital pills to directly observed therapy. We're also doing stuff with tag-ins. You can spray pills with a tag-in and then take a picture with your smartphone, and it can identify that what the medication is and that you're adherent to it. So all of these can be used for just-in-time interventions too. When people are missing doses, we can know that real time. And then I just want to touch briefly on gun violence. It's another syndemic problem. So this is a study we've done with the Gun Violence Prevention Center at MGH, looking at suicide rates among veterans and non-veterans, and how do the strength of legislation in a state on about firearms, how does that affect suicide rates? So we have 11 years of data from 2012 to 2022, and one of the key findings is that 22,000 veterans would still have been alive if they had lived in states that had the same risk as states with grade A, and those grades come from the Giffords Center. So trying to think about how do we diversify some of this thinking into other major health problems that specifically affect the U.S. And this is a small study. I'm trying to get more off the ground, but a lot of police departments use firearm simulators to train their police officers, and I want to know what happens if you put civilians through that. So we're doing some qualitative work around that as well. So just to summarize, and then we can do some questions. Syndemic problems, psychosocial and structural things, are important barriers to HIV treatment and prevention, both in Southern Africa and in the United States. We have really good treatments that intervene on problems one at a time, but that can be difficult when there are a lot of problems going on at the same time, and different syndemic problems. You can turn off depression with a really good intervention or turn off trauma, but if all these things are present, they just go right back. People just fall right back into the same system that they've been in. And so we're developing and testing this multi-level intervention to try to simultaneously break that system apart by targeting depression and trauma at the same time as providing direct food support. And we can also apply this in the US and leverage mHealth and real-time interventions across different problems, medication adherence, gun violence, and other things like tuberculosis as well. One we'll see. We'll see what future funding climates are like. These are a lot of things I'd love to do. And if funding gets turned back on, I'll be submitting a lot of grants soon. But yeah, so there's definitely a future out there. We just have to kind of be patient. And yeah, I'd like to just thank all of my collaborators, both in the US and South Africa, and all of you as well. Yeah.
Take questions from in the room, and if people online have not had a chance to put your questions in the Q&A, we will watch those.
Starting us off, yeah. I'm wondering if you've started to explore political will around the support for these types of insecurity interventions within HIV care or other funding sources that could help to sustain this in the long term. And fantastic talk.
Thank you. That is a really great question. In South Africa, certainly the problem of food insecurity is well discussed. I think at the political level, there aren't a lot of solutions being generated. And so South Africa does have a variety of different social grants people can apply for, and that provides some economic relief. Obviously not enough. I think that NGOs are one way to do it, and then also corporate. I think going straight to like large grocery chains and things like that, people who have a lot of food waste. I've been to South Africa a bunch of times. On one recent trip, I toured the warehouse of this NGO we work with, Food Forward, and they get not for the food parcels because they're too specific, the requirements, but for some of the distribution they provide to like soup kitchens and other support organizations, they get a lot of food from places like ShopRite or other grocery stores that they can't sell. Vegetables that look ugly, cans that have a dent in them, people won't buy. And so they just donate them right away. And I think that could be a more viable path. There's a ton of food waste here in the US. The farmers are destroying crops because they can't sell them. When like during COVID, all the supply chain interruptions, they were just like burning crops that they couldn't sell because there was nothing to do with them. So I think there's a lot out there. We just need to figure out how to redirect it. I think political is one way, and then also just reaching for like corporate social good is another way. Yes.
Hi, Sadie Wilson. I'm here at the Duke CFAR. I was wondering if you could talk a little bit about community engagement in terms of sort of the voices of folks of lived experience in determining the solutions for some of these issues. So, folks who are experiencing syndemics both in South Africa and in the US, and for what their perspectives are on what they need and what would be the most helpful for them.
Yeah, that's a really good question. We do work with community advisory boards and get their input as well. I touched on in the qualitative work from the K23, I didn't really present all of the intervention preferences, but this intervention is taken from what people actually want. And we asked them, do you want food parcels delivered to you? And a lot of people said, no, you can't get to where I live. It's not safe. I don't want a van outside my house bringing me a lot of food. That makes me a big target. We asked people, who do you want your interventionist to be? People said, not nurses, not the clinic nurses, which is not disparaging nurses, but in South Africa, the relationship of nurses to patients can be quite contentious at times. So we have a peer interventionist. We really tried to get people what they actually want and not just like what I put in the specific aims 5 years ago. Yeah. But I think, at every stage we try to involve key opinion leaders from the clinics and from the communities to understand this. Also, all of the people who work on our study in South Africa also live in the communities, and we rely on them too as a sort of opinion leaders. I'm going to go here because I saw you first.
I'm just kind of piggybacking off that question. I wanted to ask, how did you develop the food that was going to go in the parcel? And was it rooted in, like, you mentioned the like nutritional and biological impacts of food insecurity on depression? Was there any kind of link between like those specific foods and any kind of like impact on neurotransmitters and things like that, or just what's available? Or
Great question. So this is from Food Forward. This is the box that they developed and provide. So we're not telling the NGO what they should put in their boxes, but they're telling us. A lot of these foods are, culturally what people eat and what they want to eat. So, we're not controlling that. I tried to make that as ecologically valid as possible. Like, what would people get if they actually showed up to a soup kitchen near them? But we had to, obviously, we're buying them and providing them because of reliability of those things. A lot of the soup kitchens in the community we were working in, people to Sadie's question before we asked people, like, what do you do currently to cope with food insecurity? And a lot of people had trouble with accessing the services that are available. There are really long lines. They don't provide the kinds of food that they want. So we asked, what do you want? And then the portion sizes were small. And then availability, like some things are like, oh, we're only open on Tuesdays and Thursdays from 9 to 12. Unless you're a child, then you can come on Wednesdays. And it's like very complicated. And if you've got depression and PTSD and all these other things going on, it's like hard to navigate the schedule of how to access all of these. So this is just, what do they provide and what's like actually logistically possible.
This continues the piggybacking.
Right.
Great. So I was curious just to know a little bit more about the arm that has both the food parcel and CBT. Just a little bit about that, almost like clinic level interaction between the two. My hunch is the parcels themselves maybe are stored at clinics. So maybe, or just telling us a little bit more about that. And then so curious as well about those peer interventionists. That's a really helpful clarification. And just curious, like, how are they? It might be early days. I'm guessing you're kind of still training those folks up. But what is their sense of adding in food to this otherwise CBT program? My guess is because they're seeing it so often in their communities, in their clinics, I'm guessing they're really appreciative of this additional lens of food steps with life steps, et cetera, et cetera. But just to hear a little bit more about those early signals of how it's actually going.
Yeah. So let me talk about the food parcels for a second, which was the first part of the question. We're actually not storing them at the clinic.
Okay.
For a number of reasons, logistically, space-wise, the clinics are packed and it's not easy to do that. There's also safety. We just don't want that much of a valuable resource in the clinic. UCT has a number of collaborations ongoing, and we're partnering with a place that is a central location near taxi ranks. It's actually also next to the ShopRite in Khayelitsha. That's really big, and so it won't be strange if someone walked away from that place with a lot of food. If someone walked away from the clinic with a huge box of food, everybody would, where'd you get that? And we're also giving people shopping bags as part of the study so that they can take the food out of the box that it comes in and put it in something that actually looks like they just went to the store. So it's decentralized from the clinic, which I also think could be an implementation consideration in the future. We can't expect busy clinics to also be giving out food, but if you had some kind of referral program. So we're using a voucher system everywhere it says food parcel 1, 2, and 3. They're going to come to our study visit, do some measures, and we're going to give them a food parcel voucher that they can then take. It doesn't have to be them. It could be a family member. There's nothing identified about the food parcel voucher itself. And it's also an opportunity to practice some of the problem solving skills that we're working on. How are you going to get this home? Do you need to recruit somebody? They could go, our clinic is not far from the centralized location. So they could go right after we reimburse them for their transport. They could take that money and get a taxi home. That's sort of what we're thinking. But yeah, I think when I first had this idea, people looked at me like I had three heads. Like, what do you mean you're going to give people food? How are you going to do that? And I've been met with different responses. I think some people don't really believe it. Like the NGO, they were like, okay, well, like we'll see if this really happens, like sure, we'll be happy to provide it. And then there was a time where I was actually not sure we're gonna make it this far. I got my year 3 notice of award yesterday. So we're gonna actually do the study now. But we've been in a holding pattern for a while. And so yeah, I think that overall people are excited. And I think there's also some trepidation, like how's this really gonna work? Yeah. I guess you guys.
Thanks so much for this presentation, and also optimistic that funding will flow in the future. But curious, I don't know the timing of your qualitative work or just even anecdotally in the past year, kind of what impacts you've heard of kind of additional related to US funding ceasing to South Africa, and how that may be also impacting some of these structural elements, syndemics related to exacerbating food insecurity, PEPFAR cuts, US aid.
Yeah, that is a fantastic question. We did the qualitative work last year. So a lot of it was sort of before, 2024, 2025. A lot of it was before some of these cuts happened. But I actually have a quote from a participant who was saying that she went to the clinic to pick up her meds, couldn't get them on Tuesday, and was told to come back on Thursday. And the person that she was working with had lost their job on Wednesday. And so when she showed up, nobody knew what was happening for her, that she was told to come back and she had this really long wait and then couldn't actually get her meds that day. She did not say, well, PEPFAR funding was cut, but that is what happened. In the clinics in Khayelitsha, a lot of the adherence counselors were PEPFAR funded through different NGOs, and they lost their jobs overnight. And this person talked about, like, I showed up to get my meds and that person I was working with was gone. And they're like, nobody knew what to do. So there's definitely direct consequences. I think these data are a little bit early to fully appreciate how impactful they are.
I do have a couple of questions in the chat. They are they talk to each other, that they're both kind of the same thing. But this is from Bafour and then Dolafo. They are asking about subgroups of people in your study. So asking about food insecurity findings associated with immigration status, given that South Africa is home to many immigrants, and other questions about other subgroups of people like men who are frequently traveling in and out of South Africa.
Great question. I am like 95% sure that everybody in our study was Black South African HOSA person. So I don't think we had a lot of immigration in there. I didn't ask about like migrant workers or like people often there's a large mining economic opportunity. I didn't ask about that. Definitely we experience people migrating to the Eastern Cape during the holidays for cultural reasons and to be with their family, but I think that's slightly different than the question. So I didn't ask about that. It's a good idea though.
One thing really quick to your point about people not believing the food intervention are looking at you crazy. I imagine you guys are measuring actual consumption or what people did with the food, or if you could say. And then second, a bigger question about the design is you commented you were hypothesizing, if I understood you correctly, that meeting the food needs would put people in a better state to take this CBT and adherence intervention. But it seems like you designed the trial to do the reverse, to see if the CBT would enhance the food, being that everybody got the food. If that makes sense.
That's
Can
a
you
great-
comment a little bit more on that decision?
Yeah, that decision is just ethics.
Yeah,
I
that makes
couldn't,
sense.
I couldn't not give,
Yeah.
I couldn't push a button and you don't get food. So I think, yeah, scientifically, ideally, there would be a third condition that didn't get either, but I'm not gonna do that.
It's justifiable being it is so common too.
Yeah, yeah.
But curious about the consumption thing.
Yeah, we are asking people like, how did you actually use the parcels? Because another thing that, well, what if people just sell the food?
Right.
Then they sell it
That's-
and they use it for what they use it for. And I'm
Right.
like, who am I to say that whatever you think your needs are
Mhm.
wrong?
Mhm.
I don't know. If they sell it and can start a business from that, and that's something that sort of like begets being able to buy more food, and so maybe that becomes some form of casual employment. Great. And so yeah, we're just kind of agnostic about how they use it, but we're asking.
Be interesting to see.
We are at time.